So it's really my pleasure to moderate this plenary session. And the first speaker is Dr. Brian Lacy. So Professor Lacy is a professor of medicine and consultant at Mayo Clinic Jacksonville, and he is also the program director of the GI Fellowship. So without further ado, Dr. Lacy.
All right, well, good afternoon. Welcome to the second afternoon session. This is great. Just to let you know, I'm looking down here. This has slide 2 of 116, so don't be too concerned. So my job over the next 18 minutes is really to talk about disorders of the brain-gut connection. And I'm curious, how many of you do clinical research? All right, and how many are internal medicine providers? Okay, and GI providers. Okay, wonderful. All right, I'm going to talk to this side of the audience more than that. All right, so my job over the next 18 minutes is hopefully we all walk away with a little bit of a better appreciation for the brain-gut connection. And I want you to walk away understanding these disorders of brain-gut interaction, IBS, and functional dyspepsia. I want you to understand how I think they develop, at least give you my perspective. And then I'm going to set the stage a little bit and talk about behavioral therapy briefly and hypnotherapy very briefly to make us, I think, all understand why VR may help these very common disorders. Okay, so what is the brain-gut connection? For those of you who don't deal with this all day long, our specialty at Mayo Clinic Jacksonville, along with Dr. Kanjemi there, we see people from around the state and from around the country for disorders of brain-gut interaction. And this is this bidirectional pathway between the brain and the gut. And we have several key components: the central nervous system, the autonomic nervous system, the enteric nervous system. And then in the last decade, we've recognized that the gut microbiome plays a critical role as well. And this is a really highly evolved structure. We know that there are 5 times as many nerves in the GI tract as there are in the spinal cord. And I remind that to patients, and most of those, 90%, are sensory. We also recognize there's a huge amount of redundancy in this electrical system. As an example, you can lose 90% of the nerves innervating the esophagus before you start having symptoms of dysphagia. So when we think about this bidirectional pathway, this kind of brain connectome and its multiple facets, and the gut connectome, why is this so important? Well, it's important because, one, we recognize that the brain is important in really controlling gut function. This is higher to lower level. We talk about the big brain and the little brain. We also recognize that changes in the gut microbiome, as an example, changes in intestinal permeability can affect the brain. So it's this bidirectional pathway, and both can occur. And in between are all the moderating effects and modulating effects of the autonomic nervous system. This is why your patients sometimes feel cold, and they feel sweaty, and they become nauseated, right? So we know from our perspective that in terms of the brain-gut bidirectional pathway, in terms of its importance in our clinical field, it's important for gut motility, gut peristalsis, gut secretion. It's important for immune function. We know it's important in terms of intestinal permeability, and I've already mentioned that changes in intestinal permeability can affect the brain. It's also important because it plays a role in other things, and we're learning how changes in the gut microbiome may play a role in Alzheimer's disease and Parkinson's disease. And I wanted to show you this one slide about a study showing that when the gut microbiome was measured in patients with schizophrenia, there are very distinct changes based on changes in the gut microbiome compared to healthy volunteers. This needs to be repeated, but I thought it was really fascinating. So what happens when this brain-gut bidirectional pathway is distressed? Why? When it's dysfunctional? Well, we develop these classic GI symptoms: constipation, diarrhea, upper symptoms of abdominal pain, early satiety, nausea, vomiting, bloating. And with changes in the gut microbiome, we can also have changes in brain function. We all know the animal studies where you take mice who aren't anxious, you do a fecal transplant, and now these mice become anxious or obese or depressed. All right, so when we think about these disorders of gut-brain interaction, what we call DGBIs, these used to be called functional bowel disorders. Some of the most common are IBS, affecting 1 in 10 Americans, 10%, or functional dyspepsia, 10% as well. The core criteria, the core issue is really this dysfunction in this bidirectional pathway, and it's really a disorder of perceptive abnormalities. These patients are more sensitive in their GI tract. Literally, they are wired differently. And when we think about this electrical wiring problem and this brain-gut dysfunction, this is why I think they will be so receptive and amenable to virtual reality. Okay. Is there data to kind of support that? Is there data looking at the brain and other types of therapies to support the idea that virtual reality may help these common disorders? The answer is absolutely. So if we look back 15 years ago, in the bottom left-hand corner, we knew that there were some changes in the brain in between patients with IBS, as an example, and healthy volunteers. Kind of a big global picture. Yes, there are brain changes. We all recognize that. Then in the middle panel there, about 10 years ago, we recognized that there are now distinct brain regions involved, and there are differences between healthy volunteers and IBS patients, and also between IBS with constipation and IBS with diarrhea. Their brains are actually different. And then in the top panel, we've now recognized that in the last 5 to 8 years, not only are there differences in IBS with diarrhea patients, but if they are more pain predominant or more bloating predominant, even within that subset, there are differences in terms of brain regions. So we're really starting to hone down on this. And if we focus just on IBS with brain imaging studies, we know that, an example, in women with more severe symptoms, cortical thickness in the sensorimotor cortex is different than those with more mild symptoms or healthy volunteers. You heard some great discussions this morning, and Brennan Spiegel mentioned this, that there are actually changes in the insula and in the amygdala. We know that the salience network is changed in these patients. And if you haven't heard that concept, the salience network is really what keeps us all in balance all day long, right? We're being assaulted by external stimuli, and the salience network helps detect these external changes, helps modulate and differentiate these so we kind of stay within balance. But we recognize that patients with disorders of gut-brain interaction, that salience network is disrupted. In addition, there's something called the emotional arousal network, and we know that it is reduced in patients with IBS. They are hypervigilant, they're more sensitive, sensory thresholds are changed, and signals from the brain to the gut that should tampen down signals, that's disrupted as well. All right, so are these disorders common? Why do we even care about this? The answer would be if you survey 80,000 adults in 33 countries, the answer is these are incredibly common disorders. So about 40% of adults in any general medicine clinic or any GI clinic has some disorder of gut-brain interaction. IBS, depending on which survey instrument you may use, is about 10% of the population, 1 in 10. Functional dyspepsia, upper abdominal symptoms of pressure, pain, fullness, early satiation, about 10% as well. All right, so how are these disorders defined? They are defined really by symptoms. Abdominal pain, as I've mentioned, is really a unifying theme. These patients are hypersensitive. They are wired differently. And then they have other symptoms of whether it's nausea, vomiting, constipation, diarrhea. We use what are called the Rome 4 criteria. If you're not comfortable with that, it's a global definition to define these disorders of gut-brain interaction. Generally, we think about patients who have had symptoms for at least 6 months, and symptoms should be present for the last 3 months. So these DGBIs are diagnosed by symptoms, by the Rome 4 criteria, and really limited testing. You don't need to do exhaustive testing in these patients. A careful history and exam and the Rome 4 criteria are all you need. The key concept, as I've mentioned, this is a disorder of visceral sensation. And I like to bring out the idea of allodynia. And this is when your patients come in and they say, I put on a blouse or a shirt or I pull a sheet up and it's incredibly painful. You know, that innocuous stroking should not be painful. Some patients have that. But most of these patients have hyperalgesia, and this is where we shift that threshold to the left. So as illustrated in the slide here, we would be moving this patient down here where deep pressure may cause some distress, but now with very mild pressure, that sensory threshold is dropped, and now they sense things differently. By the way, most of these patients are also hypervigilant. They're waiting for something to occur. They're waiting for a pain signal to happen. So why do these disorders of gut-brain interaction occur? Well, I like to think about the 3 Ps. We think about predisposing factors, and we know that for many patients with IBS or functional dyspepsia, about a third have some genetic predisposition to develop this later in life. Not a guarantee, but a predisposition. And then typically something else has to happen. And as I explained to my patients, these are what I call insults. Some infection, some stress, parents are getting divorced, financial issues, physical, emotional, sexual abuse as a child. And that kind of sets the stage. Typically then some other insult has to occur. So in adolescence or early 20s, they have another infection, food poisoning, right? 10% of the US population has food poisoning each year. Why don't we all develop disorders of gut-brain interaction? Well, maybe because you're resilient. Maybe you haven't had those other insults, but many people do. So that second infection, that third infection, COVID-19, a third of people develop GI symptoms chronically after COVID. Ongoing stress or abuse can all lead to the development of DGBIs, these disorders of gut-brain interaction. What is the difference between somebody who's in the emergency room for their abdominal pain and somebody who calls you once a year for a quick checkup? That's because they're anxious or depressed. They catastrophize, they somaticize, and that leads to different ways we need to think about them and different ways we need to treat them. Why don't currently available medical options really work for these disorders of gut-brain interaction? Well, over-the-counter agents really are not effective at all. They don't treat visceral pain. That's, remember, the driving factor. We have 8 medications approved by the FDA as an example for IBS, and many of these are very effective at gut symptoms, but not affecting the brain, right? So we need to think about things differently. You mentioned, you can see here I've mentioned neuromodulators, and I want to briefly mention the concept of hypnotherapy and CBT. So the theory now is, could these DGBIs, this brain-gut disconnection, could virtual reality help? And I think the answer is absolutely, because on the one hand, I think virtual reality, whether it's through this immersive experience, this distraction, this change in time acceleration, may damp down some of these signals from the brain to the gut, but they also may block some of these signals from the gut to the brain. All right. I want to come back and just mention again the salience network. So this is kind of your executive assistant, where the salience network kind of detects and filters and integrates all these stimuli. And we recognize that in patients with DGBI, the salience network is out of whack. And this may be very responsive to treatment that focuses on the brain. So is there data to support that? Absolutely. Let's think about cognitive behavioral therapy. Because really, what is CBT, cognitive behavioral therapy? It's a proactive approach to make you change really what are bad behaviors that you've implemented that you think may help your symptoms, right? So if you have urgent diarrhea and you're IBS of diarrhea and you're worried you're going to have an accident, so you never go out on dates, but you've never had an accident, that's a maladaptive process, and CBT helps you change that. Is there data to support that in IBS? The answer is absolutely. This is a nice study from Jeff Lackner comparing an office-based to a home-based CBT program to an education program, showing that CBT was significantly beneficial at improving IBS symptoms. Okay? What about for functional dyspepsia? The answer is absolutely. And this is a nice 10-week study showing that CBT can be very useful at treating this disorder of gut-brain interaction, functional dyspepsia, going through the brain. What about hypnotherapy? Can we use hypnotherapy? The answer is yes. There are about 15 randomized controlled studies to date showing that hypnotherapy can improve IBS symptoms and also functional dyspepsia. This is a study published over 20 years ago by Peter Worrell and colleagues showing that hypnotherapy can be very effective. So now we recognize we can use CBT or hypnotherapy to affect the brain, and it improves the gut. So will VR work? And the answer is absolutely. I think it should work. Do we have data? The answer would be yes. Could we use virtual reality? So I should grab David Kangemi up here, who could give this lecture now better than I can. But David was the first person to do a pilot study looking at the use of virtual reality for the treatment of functional dyspepsia. And this is basically a self-funded study, so it was just 2 weeks in duration, because basically he pulled the money together on his own. And he took 45 patients, he randomized 30 to the experimental group, this immersive VR experience, and then he randomized 15 patients to a control VR study, which is really two-dimensional nature videos. He measured them for 2 weeks. He used a number of validated questionnaires. and asked patients to use them at least once a day. What he found was that this immersive 3D experience was much better than the sham-controlled experience just over 2 weeks. Both groups improved, showing that just this experience with virtual reality improved symptoms, but the immersive experience seemed to do much better. Side effects were about the same. And David has now started this very nice 8-week prospective study, which I think will be even better with the interaction of the Cedars-Sinai group. What about IBS? So you may have seen this article published about 2 years ago now from the Cedars-Sinai group showing that they really introduced this very novel program for the treatment of IBS. You've heard about this before. Brendan spoke about this last year. And in this immersive VR program that lasts 8 weeks, patients enter into this lobby. They can then go through different treatment rooms over the 8-week program. And in his pilot study, he showed that patients were very receptive to this and had some improvement in symptoms. We hope to start the first or enroll the first patient next week. We have a large IBS study with virtual reality with the Cedars-Sinai group starting next week. And actually all patients will be given a drug, state-of-the-art drug, linaclotide in this case, and then be randomized to either virtual reality immersive or virtual reality of a more less interactive group. Okay? So what we've learned here today is DGBIs are common. It's a disorder between the brain-gut axis that we think that based on other therapies that affect the brain, this VR should be very useful for these disorders, which are quite common. David Kangemi's in the room. We've got Sam up here, and we'd be happy to answer any questions later about other possible uses. Thanks.